well-known figure in the Egyptian Society of Nephrology. He will defend his point of view with the use of non-steroidal in CKD.
Many thanks, Professor Sharkaw, for your kind introductions, and thanks for organized committee to invite me to share in this debate. I will be pro for the usage of NSAIDs in cases of CKD without precaution. Nearly 60% of patients with CKD suffer pain. Most rate their pain as moderate or severe, and undermanaged pain is associated with a higher rate of mood disorders, maladaptive coping, and decreased quality of life. NSAIDs are recommended as a first line for analgesia and also act as antipyretic and anti-inflammatory medications. Estimates indicate that 98 million patients annually are prescribed NSAIDs. In the National Health and Nutrition Examination Survey, routine use of NSAIDs use are common in patients with CKD, and use increased with increasing the CKD severity. NSAIDs, as our Professor Amir mentioned, has a direct nephrotoxicity, including interstitial nephritis, papillary necrosis, and glomerulonephritis. Actually, it is reproducibly demonstrated on a per patient level, and they remain rare. Only less than 1 to 5% of all non-steroidal anti-inflammatory users experience such side effects. Most nephrotoxicity related to NSAIDs recovers after drug withdrawal. However, the likelihood of recovery may depend on the renal reserve. And direct nephrotoxicity from NSAIDs, including the altered interglomerular hemodynamics through inhibition of the afferent arterial vasodilatations. So this gives us a precaution to prescribe an already jeopardized renal perfusion as in shock or intravascular volume depletion. For this reason, use of NSAIDs in actually ill patients with AKI, acute kidney disease, or in the midst of renal recovery remains ill-advised. This is the best way to how the NSAIDs causing a lot of through suppression of COX-1 and 2, which will lead to sodium retention, hyperkalemia, AKI. Actual risk factors for NSAIDs associated nephrotoxicity included higher drug dosage, longer duration, concurrent use of renin RAS system, or diuretic or pre-existing CKD, or advanced age. Recent evidence has refuted that some of these risks may be less profound than once thought. Historically, we are known that there is, from the market, removal of acetaminophen combination with NSAIDs exaggerated the nephrotoxicity of NSAIDs. There is a study including around 26,000 patients. They comparing the usage of NSAIDs with RAS or without, and they're comparing it with the alternate analgesics in the presence of other antihypertensive drugs that do not affect the glomerular hemodynamics. The combination of NSAIDs and RAS inhibitors did not worsen the AKI incidence, severity, or duration. Also, another case control study, the odds of nephrotic syndrome in around 13,000 primary care patients, NSAIDs exposure for less than 15 days was not associated with greater risk. In a study of patients with rheumatoid arthritis with GFR more than 30 ml, the usage of NSAIDs for more than 3 to 4 years have a comparable kidney function decline compared with those not exposed to NSAIDs. Also, the nurse health study and the physician health study, greater cumulative exposure to NSAIDs for more than 20 years was not associated with long-term adverse kidney outcomes. So abandoning the use of NSAIDs in patients with kidney disease will lead to consequences from the therapeutic alternatives. In the chronic renal insufficiency cohort, opioid usage have a greater risk for advanced event, including kidney failure requiring dialysis and death. In a head-to-head comparison of the risk of death in patients with CKD receiving opioids versus those receiving NSAIDs, opioids were associated with dose-dependent higher risk of death at every quintile of CKD. The usage of gabapentinoids have some neurotoxicity, and in patients with an estimated GFR less than 90 mil, about 60% experienced neurotoxicity, which manifested as encephalopathy, ataxia, myoclonus, and generalized weakness. The assumption that non-steroidal, the non-NSAIDs therapies are consistently safer alternatives in patients with CKD is not supported by data. We have nociceptive pain and neuropathic pain, and the Center of Disease Control and Prevention in 2016 recommends the usage of non-pharmacological interventions like physical therapy, acupuncture, behavior management techniques, mindfulness, and music therapy. In case this is not sufficient, we have to start pharmacological, and the WHO developed a pain-laden pharmacological management, including topical steroids, and if not sufficient, we have to shift to oral acetaminophen or oral steroids, with the addition of some adjuvant drugs like tricyclic antidepressant, serotonin, norepinephrine reuptake inhibitors, and gabapentinoids. In cases not sufficient, we have to shift to morphia. A Cochrane review shows that the topical non-steroidal to be effective as an oral. In case that the pain is widespread, topical will be not efficient, and you have to shift to acetaminophen or oral steroids. The nephrotoxicity risk and the gastrointestinal and the cardiovascular risk side effects of NSAIDs is just one facet of this decision, alongside the potential for respiratory depression, central nervous system depression, and the dependence with opioids. So this is the algorithm for the pain management, as I mentioned before, and we have to put in mind that there is risk factor when you prescribe opioids. On the other hand, there is risk factors when you prescribe NSAIDs, and the physician should balance the decision of that, as mentioned by Professor O'Kale, stage 1 and 3 to 3, so through 3, no problem to use it, NSAIDs. Actually, the problem when we have advanced stage of CKD 4 to 5, the options will be between opioids versus NSAIDs. And as I mentioned before, we have to manage how to weigh the risk of both drugs and to prescribe the safety, because you cannot leave your patient in pain. As regards dosage, also mentioned by Professor O'Kale, the lowest dose should be used for the shortest duration possible. Dose equivalence across NSAIDs may be estimated with the assessment of spondyloarthritis International Society NSAIDs equivalent score. There is a score to use it. And we have to monitor the renal function. In cases of low-risk patient, we can use it. You can follow renal function and the serum electrolytes approximately yearly. And more high-risk scenarios, we can check monthly for 3 months, and then every 3 months thereafter if it's stable. My conclusion, dear professors and colleagues, pharmacological pain management for patients with CKD requires a careful, individualized risk-benefit analysis. Although it is tempting to avoid NSAIDs in patients with CKD altogether, the counterbalance of exposure to alternative analgesics such as opioids may be to the patient determined. Clinicians must calibrate their risk barometers for pharmacological pain management in patients with CKD. Oral NSAIDs remain an essential and highly efficacious class of medication. Just 1 second. Oral NSAIDs remain an essential and highly efficacious class of medication for pain management in appropriately selected individual with CKD. At the end, thank you for your attention.
Thank you very much, Dr. Tarek, for defending your opinion that I think most of us will not use it. And we are going to give you the gift of the Egyptian Society of Nephrology with Dr. Amir.
And what's the alternative, Dr. Magdi?
نورمال كيدني فانكشن ما فيش حاجه من استخدامها الا اذا كان البيشنت الرجيك ليها. ستيج 5 اند ستيج رينال ديزيز اديها له، ما خلاص ليس بعد الكفر ذنب زي ما بيقولوا. هو الكلام كله على ستيج 2 3 و4 دول يبقوا انديفيدوالي خلاص.
Actually, Dr. Magdi, in our practice we use it, but under control for short duration. But you cannot leave your patient in pain. And what's the alternatives? The alternatives carry a lot of risk, like opioids and other like gabapentinoids with its neurotoxicity.
واهم حاجه يا طارق في الموضوع ده انك انت لما تستخدمها لازم توضح للعيان تماما الهازاردز بتاعتها. وهو يقبل او لا يقبل.
It must be like this.
بس هضيف حاجه هنا بس يا دكتور صبري، ان انا في ستيج 4 او 5 لو انا حدي نون سترويدالز الانتي ستيج 5 حدي نون سترويدالز حدي اللي هو الانتي كوكس 2، لان العيانين دول بيجي لهم بليدنج بسهوله جدا من النون سترويدالز في الستيج دي، خاصه لو هم عيان اند ستيج رينال فيلير اون داياليسيس.
هو كان في سيناريو دكتور ايمن، بس طبعا عشان التسع دقائق دول الواحد ما يعرفش يقول فيهم صباح الخير. لكن في سيناريو البيشنت جاي معاه بيبتيك ألسرز ومعاه هايبرتنشن ومحتاج انالجيزك، هنا يبقى الاوبيويدز. اون ذا اذر هاند واحده لها هيستوري اوف دراج ابيوز وعندها منسترال بين مانثلي، هنا اي ويل بريسكرايب NSAIDs، ودي برضو بنقول ادفانسد CKD 4 or 5 يعني ديفرنت.
هو في برضه الترناتيف هنا يا دكتور طارق، يعني احنا ممكن ندي حاجات زي البري جابالين والجابابنتين سمول دوز ادجستد دوز، يعني دي هتعمل لي برضه بتضيع يعني بين ريليف without affecting the kidney.
They have
بس with adjusting the
they
dose.
have a marvelous sedative effect. I have a lot of patients come in a coma like a coma confused.
لا يعني ما احنا adjusted dose according للكرياتين clearance. ماشي. granulocytosis. Solindac هو one of
it's an actual non-steroidal and they claim that it's safe on the kidney.
Solindac.
Is this right ولا لا؟
I agree. لا I agree مع السولينداك واحد من mildest non-steroidal you can use, and actually this was the only non-steroidals we prescribed back in UK. Solindac only.
However, it's also a non-steroidal. It works in the COX. It has less toxicity. But it is toxic.
Yes, it
لو
is toxic.
اضطريت يبقى ده الجود تشويس لو انا اضطريت ان انا استخدم نون سترويدال سولينداك.
So we have to end this session. We have to end the debate and we'll move to the next one. I know.
احنا بنتكلم عشان الستامك.
هو less toxic.